Good morning, everyone. Good morning. Please sit, be comfortable. We're about to get started. My name is Ashkan Lashkari. I am a MOASC president. I'm also a practicing hematologist-oncologist in the San Fernando Valley, so not far from here. It's my esteemed honor to welcome all of you on behalf of MOASC and ANCO for our second annual co-joint venture, this venture focusing on immuno-oncology, and there's so much going on in this field and how it's transforming cancer care. And so we're delighted to have all of you, and we have a wonderful menu of discussions today. Just a few housekeeping issues. When you sit, you'll see an iPad in front of you. Please log in with your user, with your name and your email, and you'll be able to then see this screen on your left, and it'll allow you to access all the slides, ask questions. The questions will be directed to the co-chairs of the program, which I'll introduce in a moment, and if you need tech support, there's an icon below that you can click on, and someone from the back will assist you. At this point, I want to introduce one of the program chairs, Dr. Kim Margolin, who is working at St. John's Cancer Institute here in Santa Monica. She's also a former professor that I trained under at City of Hope, as she spent many of her years there. And so, Dr. Margolin, thank you so much for help putting this together, and I'll send it to you.
We'll
Dr. Trong, I'm sorry.
That's okay. Hi, I'm Takia Trong. I'm the immediate past president for ANCO. Ashkan and I are really delighted to welcome you to this inaugural California meeting. We've wanted to offer this to our community for a long time. We have great talent throughout our state on this really exciting new area of cancer research and discovery that is making a great impact for all our patients. Indeed, we're thankful to our program co-chairs. Larry Fong joined us from Northern California, UCSF professor and head of the Immuno-Oncology Developmental Therapeutics Session. Both he and I, interestingly, have recently decided to move on from our state, but we love that we are here, and we know that all of you will keep carrying on. So welcome, and I will pass this on to our Southern California co-chair.
Thank you very much. I'm sure that we'll never be able to gain back the few minutes we lost while everybody was enjoying the amazing meal next door and trying to get warmed up. I'm told that it will be warmer here after all the bodies have been generating heat for a little bit. So, you know, wiggle around in your chairs. And if you really want to get warm, the bathrooms are downstairs. So I have the privilege of both long-standing friendship and professional collaborations with several of the speakers, and short-term ones with several of the other speakers, and I know you're in for a very enjoyable time today. I can't tell you exactly what everyone's going to be talking about other than what you see on the agenda, but I can tell you what I will be talking about next, and that will be a primer on cancer immunology. Because of some family difficulties, we had to shuttle around a little bit with the speaker list, and one of our speakers couldn't be with us, but so Dr. Fong is going to give a more laboratory-based talk, and I will give the talk that Dr. Fong was going to give, and we'll see if I can do it justice, because I am not a laboratory immunologist, but I've been an aficionada of immunology and cancer immunology since probably the undergraduate days, and it's been wonderful to be able to see the fruits of the labors of all of the investigators in the area really come to a head in the last decade or so, and to be able to practice in the field, starting with melanoma. So on that note, there's my slides. Okay, I don't think I have, oh yes I do, I have a pointer, which points, yeah? Okay, that's the Okay, the pointer is it the red thing or the green thing? It's the green thing. Oh, great, it works great. Okay, fantastic. All right, those are my disclosures. And I have 2 slides that just list the things I'm going to try to even remotely touch upon, because there's no way we can cover the field that, of many decades and many investigators from lab and clinic in a mere 20 minutes. So I won't even try. I'm going to put my watch here to complement the timer. And, but I will tell you a thing or two about the innate immune system and about the adaptive immune system, because they're both very important in tumor immunology and immunotherapy. I found that as I was kind of going through my slides again at the last minute, there's a lot of dichotomies in immunology and immunotherapy. And so you'll see a lot of places where the slides are kind of divided into one side and the other side. And it's, of course, nothing is quite so black and white or one-sided, and I'll try to make sure you know where it's not. It's complicated and it's fun, and there's a lot that's known, and there's a lot left to be learned. In the innate immune system, there's a whole lot of different cell types. Many of the same cells do different things in the adaptive immune system. Again, lots of plasticity. Cells can change their costume, and they can change their functions depending on who they hang out with, kind of like we learn about our children in school. And then there's many substances that allow cells to communicate with each other, called cytokines and other such things. And we won't talk that much about those, but you might hear me mention them from time to time. The second slide that has topics to try to touch on will include some attention to vaccines and active immunotherapies, because that's really a critical part of how we can intervene in immunology to affect highly effective anti-cancer immunotherapy. But then there are also a number of, sorry, I didn't mean to hit that. There are a number of passive forms of immunotherapy that are also coming through these days, and there's probably a bit of a race right now between the more active ones, such as vaccines, checkpoint blockade, and cytokines, which basically depend on our own immune system to do all the work, versus the passive immunotherapies, where substances are given to us just like medications, and they kind of take care of it. But the fact is that most of the things we do are really hybrids between active and passive immunology. We have antibodies, for example, that stimulate our T cells. That's a form of active immunotherapy, but what's on the other end of those antibodies are sort of directional guides that take these bifunctional structures to a certain substance on a tumor cell or in a tumor's microenvironment, and tell it, where to exert its function. Similarly, there's these viruses and other forms of packaging structures that we can engineer, and they can cause things to happen that require our immune system. And then there are all sorts of antibodies, and some of them do a lot of the work, some of them don't do much of the work. They guide, they function, they can function via what's called antibody-dependent cellular cytotoxicity, nicknamed ADCC, or complement, which many of you may recall learning about in medical school and then forgetting about, or they may just block membrane receptors and inhibit signaling, such as things like HER2 or VEGF receptor blockers. So you're going to see a lot of diagrams. I don't expect you to memorize or even be able to read what's on some of these diagrams. They're very small font, but the internet is full of really amazing diagrams. If you use the right keywords, you can come up with a lot of stuff. And so you'll also see that I don't have a lot of attributions or citations on these slides, because they're all in the public realm. And very few data slides in my talk. You'll see a lot of data slides in the other talks. So this, however, is, I thought, a rather nice way to picture what happens in the immune system in terms of what things kind of look like in a schematic fashion, and what is actually being done by those structures. For example, and this is just 4 quadrants here. If you take a look, well, I put it down in larger font. It involves cells, products, receptors, functions, and structures. And so, for example, let's start with the left upper quadrant. You see antigen presentation, and that takes place and is mediated by a cell that's got these little finger-like structures sticking out that are otherwise known as dendrites, and therefore the cell is called a dendritic cell. But there are many different kinds of dendritic cells that function differently from each other. They're found in different parts of the body and that interact differently with different cells of the immune system. The dendritic cells are considered our professional antigen-presenting cells. It's a very important part of what they do. They can also suppress immune reactions, and they can as I say, interact with a lot of different cells. They're very important in vaccine strategies, for example. They present antigens. Another very important function is the what we call the histocompatibility or major histocompatibility or HLA molecules that are divided. Here's one example of that sort of dichotomy between class 1 and class 2. Class 1s mediate activities of CD8 cells, which are the primary cytotoxic cells against pathogen infected cells and against tumors, whereas class 2 form a more supportive function and involve also these cell-cell interactions, but are more involved in helper cell functions. And on the left lower quadrant, you see protein production. Most importantly, ligands for different receptors that have different functions inside the cell, signaling, as well as antibodies that come out of B cells, and they look like this, and you'll hear, I think, a lot more about those structures from Anna Wu in the next talk. Cytokines and chemokines that mediate these interactions between cells. Chemokines are often involved with gradients that cause cells to migrate from one place to another or to chemotax. In the right upper quadrant here, you see some of those toll receptors that I mentioned that bind to the surface or the inside of the dendritic cell, and they mediate signals that are shown by RIG2 and MD8, and there's others, and they signal the dendritic cells to do various things in their path to interact with other cells. And then here are some of the really important antigen receptors, and if you really understand this slide, we don't have to do the rest of the talk, really. But CAR stands for chimeric antigen receptor, and there are various structures that can be used that can be used to engineer T cells to recognize antigens that you want them to recognize and then to function in certain ways. It's a whole exciting field now, and somehow the people who make CARs and to use them have managed to find an automobile name for every single structure that has been invented for those things. You can also take the native T cell receptor and convert it into something that also recognizes antigens of interest, and then we won't go into this right now, the NKG, the natural killer cell CARs. So this one I see is even more difficult to read, which is just as well because in this slide, this is getting very esoteric, and it talks about some of the many different functions that T cells can take on in terms of their plasticity. Sometimes they can go in one direction from an early cell to a later cell and never go back because there's permanent change that occur. In other intermediary states, the T cells can shift between certain phases of their memory, and as you know, both the B cell and the T cell component of the immune system are very, very rich in memory functions, and that's how the immune system, the innate immune system works right away immediately. It doesn't have memory, but it has functions that can step up to the plate immediately and then give rise to things that happen in the adaptive system, whereas the adaptive system is full of many different memory functions that are conferred by complicated, genetic processes, epigenetic processes that happen outside of the sequence of their genome, and they confer many of those functions. And they form the basis of many of the experimental testing that we do when we're trying to find out if some kind of an immune intervention is really creating a permanent change in the immune system that is capable of inducing memory. We do things like curing a mouse of a certain tumor by removing it and giving some kind of a therapy, and then re-exposing the mouse to the same stimulus, to the same tumor type or the same pathogen. And if there's a quick and thorough response against that secondary exposure, it's considered to have occurred on the basis of effective immunologic memory. I won't try to go into all of these details about the proliferative potentials, the inhibitory, the epigenetic, but there are, again, you can go as far as you want into these immune phenomena the more you want to learn. I'll just mention one final thing. So again, one of those dichotomous slides where up in the left-hand corner, this is a form of acute antigenic stimulation and chronic antigen stimulation, where the sequence tends to result in suppression of effective responses that are beneficial to the host. So chronic diseases like rheumatoid arthritis or inflammatory bowel disease are actually pro-tumoral, whereas acute stimulation often induces that innate immediate response, and then that gives over to the effective adaptive immune responses that are antigen specific and memory inducing. So you're going to kind of go between highly complicated slides that are impossible to read and ones that are a little bit more user-friendly. So here's one of the more user-friendly ones that imparts what I think are two important messages. One is that of T-cell activation, which is over here on the left side, and a very simple concept that involves the need for 3 signals for an effective immune response. One is an antigen, and here you see a T cell and an antigen-presenting cell, always illustrated by those little dendritic things that are sticking out, and it's always a little bit bigger. Here you see MHC or HLA, they're the same as each other, class 2. Here's an antigen, which is actually made up of a little string of amino acids in a short protein segment that could range from around 10 to 15 amino acids in length, and then the T cell receptor. In this case, this particular interaction is pretty antigen specific, but not quite as antigen specific as ones that involve MHC class 1 and CD8 cells. Signal 2 is what we call co-stim or co-stimulation, and the molecules are things like CD28 on the T cell and CD80 and CD86 on the antigen-presenting cell, which could itself be a tumor cell in many cases. And again, so it's been whited out now, but here you have the antigen-presenting cells, MHC molecule, and then the T cell receptor here with a little peptide in between. And then finally, the third signal is to proliferate and augment this response or this activation by the antigen-presenting cell or other T cells secreting any number of cytokines. Cytokines are generally designated as IL or interleukin to designate that it's between leukin, white cell, and so they mediate those interactions. And then they turn on that third. So you have signal 1, signal 2, and signal 3. On the right side of the slide, you see a very simplified version of what we borrowed from the neurologists and call the immune synapse, which is a place in between cells where interactions between a ligand and a receptor occur, and then some event follows, usually some kind of a signal cascade in one of the 2 molecules. And ligands and receptors can be receptors and ligands. It doesn't really matter which one's which. Sometimes the ligands are soluble and the receptor is fixed, and so on and so forth. So we won't talk about every single one of these. And the immune synapse just gets more and more complicated depending on how recent the publication is that you read about it. Another relatively simple slide here, which shows, just reminds me to tell you that the way that T cells kill target cells in general has to do with the production and secretion of what's called granzymes and perforin. They are enzymes that essentially permeabilize the surface of the cell. That is of interest here. Sorry, this is the T cell and this is the tumor cell. Also, gamma interferon is secreted and causes cascades that lead to a more organized form of tumor cell death. And then there are some other ligand receptor functions that can occur between T cells and tumor cells that can sometimes lead to apoptosis and other forms of cell death. And here is just a way to show you that PD1 stands for programmed death 1. It's a receptor on T cells and other cells in the immune microenvironment. And when PD1 is engaged by PDL1, programmed death ligand 1 or 2, it can cause the death of an activated T cell. This is what we used to think is how things worked, and it was very simple, but we've learned that it's way more complicated than that. Where the PD-1 is, what it does, what the cells do that have it on the surface, and so forth is not a simple programmed death, nor is a simple programmed death ligand something that causes the death of T cells. But again, not enough time to go into that from me today. You'd probably be hearing much more about that in different pieces from different speakers. So this is some of you have young children. You may remember, I didn't put a video in here, but in that little film called Encanto, there's a cute song called "We Don't Talk About Bruno," but we don't also talk about, where's my forward? Oh, okay, well, my animation's not working here. Basically, this is supposed to show B cells that we're not going to talk about in great detail. Sorry, I was using the wrong button. We don't talk about B cells because B cells are really, have been considered a minor part of the immune system against cancer and against other diseases that involve viruses. Like in HIV-related diseases, it became evident early on that people were making gobs and gobs of antibodies to things, but those antibodies weren't really helping to get rid of the disease because it was complicated and it was so immunosuppressive against T cells. Many B cell functions are dependent on help from T cells. Some are not, but those are mainly against pathogens like bacteria. So it didn't get billing on this talk, but it's coming back, and we'll talk very briefly about tertiary lymphoid structures, and you may hear more about B cell functions from others and about what you can do engineering-wise, again, from the second speaker, Anna Wu, who's been doing this throughout her career. We also won't have a lot of time to talk about innate cells other than what I mentioned to you earlier, but when you see the terms, you'll see terms like natural killer cells, NKT cells, which are sort of a hybrid between NK cells and T cells, and they dress the part, and they also do some of the functions of both types of cells. And there's a number of other cell types, and we won't try to talk about all of these pathways because I'm running frighteningly low on time. But a little bit about dendritic cells. We've talked about them a little. You recognize them now in the middle here. A related cell is the macrophage, and macrophages also come from different lineages. But here you see them sort of talking to the T cell and showing, if you're astute, you will notice that here are those three necessary stimuli, 1, 2, and 3. And then there are some of the types of T cells that are talking to the B cells, including naive ones, including H1, again, another dichotomy, helper 1, which is thought to be in charge of those reactions, which will be anti-tumor and pro-immune. TH2, or anything where you see 2 on the end, you'll see DC2 and a variety of things, generally refers to something that's suppressive to the immune response to tumor or pro-tumoral. And TH17 is a complicated concept because it's generally considered one of the more regulatory or suppressive types of T cells, but there are times when it can be sort of lassoed into something beneficial. But it's also involved in a lot of allergic type reactions. So you'll hear terms today from some of the other speakers, which I won't go into. Tumor-infiltrating lymphocytes, those can be used to refer to what the pathologist sees in a piece of tissue that may be removed, and you can use those to have a sense of how immunogenic that tumor might be. But we also have therapeutic tumor-infiltrating lymphocytes that can be teased out of tumors in large enough quantities, characterized, and then given back to usually the same host. And when given in large enough numbers and functionally doing what they're supposed to do, they can lead to very remarkable tumor remissions. So I promised you tertiary lymphoid structures that are seen as follicles, lymphoid follicles in tumors, secondary lymphoid structures being in the lymph node, and primary, I think, being in the bone marrow and or the Peyer's patches. So you see, as I said earlier, I think that they have dendritic cells. They have what's called high endothelial venules. They have B cells. They have CD8 or cytotoxic type T cells. They have regulatory T cells, fibroblasts, and CD4 cells. And then there's cells that are all around the follicle that are considered parts of the lymphatic lining, kind of analogous to endothelial cells. And these are very important. They seem to be associated with favorable outcomes when seen in tumors, but there are many different forms of these follicles, and it's a hot topic currently, so stay tuned for that. Here's another one of the more complicated slides that also talks about the lymphoid structures, but it's really the same information I just showed you. Stroma is an important part of tumors. It's dynamic. It's, we think of it as holding things up, but it's also got cells going in and out, cells that live and die, cells that talk to each other. They attract other cells. Another area to remember, and we will hear about the, I imagine from Dr. Kian that we will be hearing about more about stroma and the function of this part of the tumor microenvironment later on. I hope I got your name right. Again, dichotomy, cold and hot tumors. Hot tumors are considered the ones with a lot of tumor-infiltrating lymphocytes, possibly with a lot of mutations in tumor cell DNA, and possibly with the expression of PD-L1 on tumor cells and other cells. The ones that are cold don't have cells in them. They don't have T cells, or they're way out on the margin, heading in the wrong direction. I suspect that others will talk about it in some of the clinical data presentations, so again, I'm not going to go into great detail on this. The diet, the microbiome, and metabolic considerations are becoming very hot topics as well. I would venture to say I'm kind of a cynic about the dietary component, at least about how we study it now, and I would say there's very little evidence that we can add things to the diet and have those things result in favorable outcomes, both in terms of getting certain cancers and in terms of being cured of them. But there are definitely things that we should remove from the diet that have been shown to help, and if you will, include among diet, things like cigarettes, but also, processed foods. I'm starting to become a believer, and of course, red meat. The thing about antioxidants is they don't necessarily do what people think they do, and much caution should be exercised. As far as the microbiome goes, that's really a topic for another full week symposium, and I think I'm going to skip that because it's incredibly complicated, and although there are some therapeutic approaches now, and it's looking pretty interesting, it's probably not ready for the kind of prime time we're going to be talking about today. Metabolomics of cancer immunology are also super interesting, super complicated, and I don't feel qualified to even talk about that. Immunoediting is a concept that was sort of created by one of the real fathers of tumor immunotherapy, who's still at it. I just heard him talk a few days ago. And it's 3 simple steps in the sequence again, it's very highly complicated, but it's one way to think about it in a very sort of Darwinian, almost fatalistic way, which is that initially the immune system is capable of eliminating malignant cells. Ultimately, a whole lot of selection happens, and an equilibrium is reached between the immune system and the malignant cells, and that may be dormancy. A lot of things get introduced at that point, and then, unfortunately, escape is when the tumor cells have become so heterogeneous and so difficult for the immune system to perceive and eradicate that the tumor escapes from that control. Okay, vaccines. I'll try to be very brief. You're going to be hearing more about that. The 2 diseases for which we have preventive cancer vaccines are human papillomavirus for cervical cancer and head and neck cancer, and hepatitis B virus against chronic infection, which can lead to hepatocellular cancer emerging. And you get B and T cell responses from both of those. Vaccines for cancer therapy, of course, the holy grail, and a lot of different approaches are listed on this slide. I won't try to go into any of them in great detail. The compositions are multifold. The antigens, the way they presented are many, and the delivery methods and the adjuvanting them, in other words, giving something with the vaccine that causes dendritic cells to present them to the immune system and to react, are also complicated, and different companies and different academic groups are doing them differently, kind of in parallel, which is what they should be. So here's some illustrations. You can use cells killed, you can use viral-based, you can use peptide, as I mentioned earlier, and nucleic acid-based cancer vaccines, which are now, you'll probably know they're analogous to some of the COVID vaccines made from messenger RNA. It's shown again here. I think this is really just a repeat of what I just said. And this is, I know that some of the other speakers are going to be talking in greater detail about the personalized cancer vaccines that are based on neoantigens that arise from unrepaired damage to DNA that can be highly immunogenic. So I won't steal their thunder or drag this on, since I'm already over time. These slides I have little doubt you're going to see already in other speakers. And I think, Larry, will you be talking about CYP-T? No, okay. That used to be one of Larry's major acts, but that was a long time ago. So this is a dendritic cell-based vaccine for prostate cancer, which is very, very modestly active, but it's being, it's the topic of some efforts to make it better. And what this consists of is the use of a GM-CSF, which is it can mobilize white blood cells from the marrow, but it's also a sort of a chemotaxin for the immune system, and it's inside of a plasmid. It's a plasmid, right? That introduces GM-CSF with PSA. PAP, sorry, PAP. I haven't thought about this in a really long time. Sorry, it's right there in the slide. Why don't I just look at it? PAP, GM-CSF, and that's taken up by the dendritic cell, which then uses these, the GM to stimulate immunity and uses the PAP as the antigen, or breaks it down into the antigen, presents it, and then stimulates mainly T-cell responses. So you get a little bit of a benefit in survival, actually, in patients with prostate cancer, receiving that when compared with placebo. When the immune response is maladaptive, and I think you're going to be hearing this from Katy, from one of the speakers, about what happens when overly stimulating the immune system with these drugs that we're using, these immune checkpoint blockade and others in the past, cause a breakage of the tolerance against our own tissues, and thus the development of autoimmune-like syndromes such as colitis and dermatitis and pneumonitis and all sorts of other itises. So I won't steal someone else's thunder on that. This is a small version of the spectrum of different inflammatory syndromes that can result. And so I would say you're now ready for graduate school in tumor immunology. This should be the last slide, but I think there's one or more. We talked about the stroma already. It's intimidating, but it's also exciting. It took a long time to get to where we are. Many villages, that's the third of the 3 cancer immunity cycle publications from Chen and Melman, I believe, and on that, I will thank you for listening. If you like puzzles, you'll notice that the last slide had the same figure as this one, but there's a difference. And if you want to look on your screen, you might be able to find it. So thanks a lot. I'm sorry I went over by a few minutes. And the next speaker is, I don't think I'll have time for questions, but we'll have a panel. And the next speaker is Anna Wu. Anna is going to be talking about imaging. I will say that because there'll be many aspects of imaging. Anna is a professor at City of Hope and the head of the immune imaging, what would you call it?
Well, Immunology Theranostics Department, Theranostics Program.
Okay, better said. And also a dear friend of many, many, many years. So, of course, I welcome Anna on stage.
Thank you. Okay, we're done with graduate school, on to postdoc. Let's see. Got it, and which one is the, oh, the pointer, I see it. Okay, we're good, thank you. First of all, my financial disclosure is the most important one, being that I'm a board member and consultant to ImagineAb, and ImagineAb is the one that's developing and commercializing the CD8 imaging agent that I'll be talking about a little later. My other disclosure is that I'm not an MD, despite what it says in the program. So actually, many of you know more about these things than I do, so that's the other disclosure. So I want to talk a little bit about the past, but also look to the future of how we monitor patients who are on immunotherapy. And I'm really going to go back in the past because, we really do need means to assess whether specific tumors are responding to a given therapy and of course, whether the patient is responding to a given therapy. And from the get-go, we want these tumors to go away. So measurements of tumor sizes, provide an early indicator as to whether a patient will ultimately undergo clinical benefit and survival. So, but my good friend Wolfgang Weber actually introduced me to this next paper. If we dig a little bit and see where did this concept originally come from and some of the measures come from, we go back to 1976. And this was a classic study done using, the methods were a mattress, wooden spheres from 1.8 to 14.5 centimeters in diameter, foam rubber sheets, 0.5 centimeter or 1.5 centimeters thick, and 16 experienced oncologists armed with rulers or calipers. And so it was a measurement study. The question was how these oncologists would measure the spheres underneath the mat and make their estimates as to how large they were. And the outcome of this was that they found that the oncologists could reproducibly determine a 50% difference in the bidimensional measurements of these wooden spheres. But if you ask them to look for a 25% difference, then the error rate went up a lot higher. So this became incorporated into the WHO criteria in 1981, where originally complete responses were defined as complete disappearance, partial response if there was a 50% decrease in the tumor size based on bidimensional measurements, or using ruler or caliper, or in those days, imaging consisted of X-ray and liver scans, and then progressive disease if you had a 25% or greater increase. So fast forward to around 2000. By then we needed, first of all, we had better imaging modalities. We have CT, we have MRI. We also need better and simpler criteria to understand, at least, for example, for assessing responses in clinical trials as to whether patients are responding. So now we have moved to, it's still away from the cross product or the area that you're seeing on the scan, rather to linear dimensions, the longest diameter of a lesion. Also have moved from, instead of then, because we're looking at length as opposed to area, instead of looking for a 50% decrease, now the standard became if you see a 30% decrease in the sum of the linear measurements, and also incorporating, just looking at more specifically 10 lesions, 5 per organ. And then, as you can see, by 2009, the field had moved on to RECIST 1.1, which further streamlines the process. It does incorporate criteria in terms of how to evaluate lymph nodes, depending on how big they are, and also reduces the number of lesions you have to measure, but all in all, still very much based on what is the size of these tumors on CT, MRI, and and how is that size changing, the linear dimensions. And I think also RECIST 1.1 allows you also to include the results from FDG PET. Okay, so this worked well for a long time. Still, RECIST 1.1, we're using it routinely. But there are challenges. For example, if you have cytostatic instead of cytotoxic therapies, you don't see the same kinds of tumor size reductions. And then, of course, in the immuno-oncology field, we sometimes see this process called pseudoprogression, where tumors may look larger first on immunotherapy and ultimately resolve, but that increase in size is not necessarily due to tumor growth. It can be due to the influx of active immune cells into the tumor environment. So here's a couple examples on the slide where you can see early on these patients look worse, but if you press on with your immunotherapy, it just takes longer sometimes for these lesions to resolve. So that led to the introduction of iRECIST, or the Immuno-Oncology RECIST criteria, still based on tumor size measurements, but now when you see what looks like progressive disease, it can be considered unconfirmed progressive disease, you can keep the patient on treatment, scan them again, and if at that point either the tumors continue to progress or they start to shrink in size, you can reclassify patients, for example, as having immune-confirmed progressive disease, or if there's subsequently tumor shrinkage, it resets the bar in terms of following your patient. So that's a twist, still based on tumor size, but it takes into account that some of these immune responses take longer. Okay, now the next thing that happened along the way, and I've already alluded to it, has been an addition of metabolic imaging to anatomical imaging. So here we're using fluorine-18 labeled fluorodeoxyglucose, PET, which is a scan, as you know, for measuring the glycolytic activity of tumors. And so this led to the development. This is still a work in progress. I wouldn't say it's uniformly accepted, but a work in progress to develop criteria such as PERSIST for solid tumors, very analogous, where instead of looking for changes in tumor size, you're looking for either increases or decreases in the SUV of a lesion, the standardized uptake value. So you can see the PERSIST criteria there in the third column for solid tumors. But then, of course, immune cells, when they're activated and infiltrating into tumor cells, can also be very metabolically active, and that leads to challenges in using FDG PET. So in analogous with what I said before, there's now iPERSIST, which is modified for monitoring immunotherapies, and again, it involves a subsequent scan to see if things resolve or not. So that's the metabolic imaging. And what I'd really like to talk to you about now is what is the future of imaging in immune responses in immunotherapy, because what we really want to do is actually image those immune responses more specifically than anatomy or metabolic imaging can tell us. So what I've done here is listed a few general approaches towards trying to image immune responses, and I've chosen these because actually each of these has a clinical example. So these are things that are coming. They've moved out of the lab, out of the mice, and are being tested in the clinic, although many of them are still very early. But it gives you a hint of what's to come, and that the fact that we might and should be able to get to more specific imaging. So the first example is altered cellular metabolism. We've already seen an example of that, FDG PET, because immune cells do upregulate glycolysis and do give you a stronger signal. And there's a lot of additional metabolites that people are looking at, such as many of you are familiar with fluorothymidine, which is used as a proliferation marker. And now people are looking more carefully at additional nucleoside analogs, such as clofarabine or ARA-G, which are more specifically taken up by immune cells that are activated as opposed to tumor cells. So hoping to distinguish between the biology and the nutrient usage of these. And so that in square one there, you can see an example of imaging ARA-G in a patient. This is actually, I think this is a patient, and they were looking at whether signals in the lymph nodes went up or down following treatment. Another approach that we've used for a long time is taking cells out and labeling ex vivo. This has been done for imaging infection for decades using indium-111 auxine. And so an example 2 shows the PET version of that, where now we can use zirconium, which is a PET isotope with a 3-day half-life, zirconium auxine to take white blood cells out of patients, label them, infuse them back into the patients, and see where they go. So that's an image from Susie Lappy's work, looking now first in normal subjects, but hopefully going to move on shortly to looking at more interesting cells in patients. Third example is using reporter genes. If you're going to be taking your cells out, engineering them with CAR-Ts, et cetera, you can also add in a reporter gene, which gives you something that's imageable. The third example shows using a modified tyrosine kinase from HSV in conjunction with a nucleoside analog called FHBG, and this is CAR-Ts, well, it's actually a Zeta-kind study in patients with glioblastoma, where the therapeutic T cells were administered locally, but you can see on treatment there was a stronger signal showing you that those therapeutic cells were in the lesion and were proliferating. And then Kim mentioned activation markers. She mentioned granzyme B and interferon gamma as markers of telling you that those T cells in there are actually active. So here's an example of group that's developed methods to actually directly measure granzyme B. They made a substrate analog, labeled it with gallium-68 for PET imaging. I looked, but I couldn't find a clinical image, but here's a mouse image, but it is in these types of agents to directly measure granzyme B activity are in the clinic. So finally, what I'd like to turn to is what we've been working on, which is actually measuring cell surface targets using antibodies, as Kim has already introduced. We have all those CD markers. There's like close to 400 different CD markers and corresponding antibodies. We can use those to develop immuno-PET imaging agents. These include the lineage markers, as well as functional markers, markers of activation, exhaustion, et cetera. So our favorite target, of course, is CD8 because this is the classic marker on those cytotoxic T lymphocytes. They are a hallmark of effective cancer immunotherapy. Shown here is just biopsy-based, looking at melanoma patients on a checkpoint inhibitor. You can see that the increase, I really am out of time here, in CD8 infiltration is associated with response. So what we've done in the laboratory has been to make engineered antibody fragments that, first of all, for mice, bind to the CD8 T cells. And in this image on the right, you can see non-treated tumor, a treated tumor, but we're looking at the T cell signal, and you can see it's a lot stronger and hotter, and the tumor is smaller, and the spleen is very hot, showing you that in vivo, non-invasively, we can measure that in mouse models. So here are our workhorse imaging agents on the left for the mice, and on the right is our clinical agent. And this just summarizes the fact that this is actually a very universal approach to looking at responses to immunotherapy. We and our collaborators have published using CD8 imaging to evaluate in mice responses to checkpoint inhibitor therapy, adoptive cell transfer, combination therapies, oncolytic viral therapy, bispecific antibodies, and most recently, external beam radiation. And also non-oncologic applications, stem cell transplantation, graft versus host disease, and even infectious disease. So on to the clinic. So this is from the phase 1 study showing what can be done in patients using that zirconium-89 labeled CD8 specific minibody. Here's just the first patient showing you, if you look at the whole body scans, we see the lymphoid tissues, spleen, bone marrow, lymph nodes. This is a stable signal either at 6 hours or 6 days. And FDG PET, you can see this patient had a small melanoma lesion in the shoulder area. And on the CD8 immuno-PET, you see colocalization of signal in that same spot and persisting over time, over the week. And a subsequent biopsy confirmed the presence of CD8 T cells in that lesion. So this was a summary of the phase 1 study. Here are all 15 patients. This agent was designed to have rapid clearance. So these are all images at 24 hours after injection, although you can see images as early as 1 to 2. You see the spleen, bone marrow, lymph nodes across the patients, and depending, you can see tumor uptake in some of those lesions, depending on the status of the patient. So that looked good. It allowed us to set basically the RP2D, where we're using 1.5 milligrams of protein, 1 millicurie of zirconium-89, and imaging at 24 hours. So this is the format of our ongoing phase 2 studies, format of one of several phase 2 studies, which is to look both pre-treatment, then patients go on to standard of care checkpoint inhibitor therapy, and then after 4 or 5 weeks, there's an on-treatment CD8 immuno-PET and a corresponding biopsy. So this is 2 melanoma examples. On the left, if you look especially at the bottom, you can see pre-treatment FDG. There's the melanoma. Here's the CD8 immuno-PET, and you can see it's kind of heterogeneous and maybe more restricted to the rim of the tumor. After 4 or 5 weeks of immunotherapy, here is the repeat CD8 immuno-PET, and now you can see the tumor is hot through and through. And at 4 months, here's the follow-up FDG PET showing shrinkage and diminishment of the FDG signal. So here's a patient that responded. On the right, I think actually this is one of Dr. Margolin's patients, which is a patient that showed no response on the CD8 immuno-PET and also was an example of progressive disease. 2 other quick examples from non-small cell lung cancer and renal cell carcinoma showing you the pre-treatment and on-treatment CD8 PET scans with an increase in the signals. And here are the corresponding biopsies showing you the increase, showing that there really were more CD8 T cells in the patients that, who were on treatment. showed an increase in the PET signal. So we presented last year correlations between the immuno-PET signal and the immunohistochemistry. The strength of the correlation varied, but some considerations are that there are, of course, sampling limitations when you're looking at biopsies. There are also definitely heterogeneity issues, both intratumoral, intertumoral, and even the question is CD8 immunohistochemistry really the gold standard, because you're really just looking at one little needle biopsy. So that work continues, and let me just wrap up here. This is where we are with the CD8 immunopet as of now. It looks promising. We are looking at correlations. There's variable strengths of correlation depending on the PET parameters you look at in the clinical scenario. But early imaging does look promising, and we have ongoing studies, including looking at CD8 immunopet in neoadjuvant trials, as well as there's actually one study looking at immune-related adverse events, and then, of course, retest reproducibility as we try to move this agent towards FDA approval. So hopefully, in summary, I've given you a review of what we've done in the past, and truly are still relying on heavily now, which is anatomic imaging, and adding in metabolic imaging, which is giving us important biological information. But I think there's a lot of excitement for the future, because I've shown you direct imaging of those CD8 cytotoxic T cells. But as I mentioned, there are a number of other really interesting and promising approaches toward directly imaging functionally immune responses in patients that are going to hopefully help us out in the future as we try to figure out what's going on here. Thank you.
Thank you very much, Anna, and thanks for sticking to time, unlike me. I have drawn out, by lunchtime we'll be okay. By the end of lunchtime, we'll be back on time. The next speaker, who we're very, very delighted to have here, is Dr. Allison Betof Warner, MD, PhD, who is now with us from Stanford as the Mark and Mary Stevens Endowed Scholar in Melanoma. Dr. Betof Warner is going to be talking about the optimal treatment duration, but has many, many talents, and hopefully you'll ask her questions about her many fields during the question and answer panel, including exercise physiology and the immune response and adoptive cell therapy for cancer. Thank you, Allison.
All right. Thanks, everyone, for having me. I am going to talk about a topic that I've got to say I am not the most recent expert in, but have done some previous work in this area, and is something that I think we are all still struggling with. So we have patients on immunotherapy, they respond, and we have no idea how long to keep them on treatment. So we'll talk a little bit about this field and where we are, and I think where we need to go, most importantly. So these are my disclosures, none of which I think are particularly relevant to our topic today. But, you know, many of us come from a medical oncology background where we were taught, you know, a patient has metastatic disease, you start them on treatment, they stay on treatment forever. And so when we started this, I think there were many of us that thought, well, patients are going to start immunotherapy and they will stay on treatment forever. And some of the early studies were designed that way, but we all know that there are a multitude of problems with that, and it may or may not be really necessary to treat patients long-term, certainly maybe not forever. Some of the key issues, obviously, physical toxicity and the risk of side effects, though many of us agree that the risk of side effects are highest early in the course of immunotherapy treatment. We all know there are patients who develop late side effects a year and even 2 years into treatment. So if we can avoid that, that would be ideal for our patients. But also the cost of these treatments, both to the patient and to the healthcare system. And for us, chair time, visits, all of these issues, these patients take up a considerable amount of time and space in our clinics. And if they don't need to be treated, then we certainly shouldn't be continuing to do that. So lots of ideas here about how we should or could think about early cessation and monitoring of our patients. Certainly, most of the work here is in patients who have had a complete response, and I will talk about that. Less, but some interest there in patients with a partial response, particularly deep partial responses or what we call near CRs, and a lot more concern about how do we handle this in patients with stable disease who we know that their outcomes tend to be not nearly as good as patients who've had a deep PR or a CR. Lots of ideas on how to do this, including imaging, monitoring of ctDNA. I was just at SITC and someone was discussing how they do ctDNA on their patients once a month, and I, quite frankly, was a little bit mind blown. I also am not quite sure how you get that reimbursed, but people have lots of ideas on how to do this. Biopsy of radiographic remnants, either CT or PET positive lesions. And then certainly the idea that we can re-challenge a patient if they were to stop and then progress. And that's really where my work focused, this idea that, oh, if a patient responds and we just stop their treatment, well, we'll just start again, no big deal. And as I will mention as we get there, we found out later on that that is not so much the case, at least in melanoma. So what was done on clinical trials? So some of the earliest clinical trials did exactly what we've always done in oncology, which was until progressive disease or evidence of clinical benefit, which was basically investigator discretion, or certainly unacceptable toxicity. Many trials have set an end date of 2 years, and some trials an end date of 1 year on treatment for complete responders. So we'll start with melanoma, partially because it's my favorite thing to talk about, but also because it is the disease in which we've had the longest experience with immunotherapy, and so we have a lot of long-term complete responders and deep partial responders, and so at least some depth of data here. So we know that about 40 to 60% of patients with advanced melanoma treated with an anti-PD-1 based therapy will have an objective response. About 2/3 of those responses are durable and or permanent. But the optimal duration of therapy, even in these patients, has not been defined. Many of our trials in melanoma used a 2-year end date, and that is what clinically many of us have done in the absence of other data. So if we look at KEYNOTE-001, which was the trial of pembrolizumab for advanced unresectable and metastatic melanoma, the median time on anti-PD-1 treatment was 23 months. There was an option on this trial to keep your patients on indefinitely, but many investigators did stop somewhere around the 2-year mark. Median time from CR, from complete response to last treatment, was 7 months. 16% of the patients on this trial had a complete response. So 88% of those complete responders were still in a complete response 30 months after their CR. Okay, so almost all patients stopped treatment, and 88% or 90% of them were still in a CR 30 months later. 90% discontinued, and 64% of them did not require additional anti-cancer therapy at the time of this publication, which was 2018. And we have some other data coming out that would suggest that that is still true. If patients made it to the 3-year mark, the chance that they were going to need treatment at 5 and even 10 years is exceptionally low. That's work done by my fellow Kim Liu. In a more real-world experience, we looked at a single-center experience when I was at Memorial Sloan Kettering of 102 patients with a complete response who were treated off-trial, primarily off-trial. More than 3/4 of these patients were off of a clinical trial. And so some of the pre-selecting factors that we know go into that were kind of out the window here. So the median time in this cohort on anti-PD-1 was 9.4 months, so unlike that 23 months. The median time from CR to last dose was actually 0 months, so there was a push at that time to really stop our patients as soon as patients were getting a CR for fear of toxicity. felt like really patients were getting to this CR mark, we should get them off treatment, get them back to their lives. There were some patients actually that stopped prior to CR. Many of those were for toxicity, so you can see the range here is actually minus 12 months. So some patients who stopped for toxicity with a deep PR and ultimately were found to have a CR on biopsy. And the 3-year treatment-free survival in this group was 72%. So still excellent, and I think very reassuring to all of us, but not that 90% number that we've been throwing around from clinical trials for many years now. The 3-year overall survival from the time of CR in the complete responders, this is 102 complete responders, was 82.7%. So even in patients who stopped immediately after getting a CR, their overall survival was quite good. But about 25% of them did go on to require additional therapy. As I won't have time to go into today and isn't the topic of this talk, but just to mention that the idea of retreatment here, that we could just put these patients right back on the PD-1 that they responded to and had a CR to, we looked at that in 78 patients of this cohort. The majority of which were retreated with single-agent PD-1, some of which got combination ipilimumab plus nivolumab. And unfortunately, even patients who had a complete response the first time they were treated with anti-PD-1 only had about a 15% response rate to rechallenge. So the idea that you can just rechallenge a patient, I think, is not accurate and something we shouldn't be telling our patients when we talk about discontinuation. Now, that doesn't mean we shouldn't be discontinuing, and that also does not mean that these patients wouldn't have gone on to just develop resistance even if we'd continued, right? They clearly have a resistant melanoma clone that was not going to respond to anti-PD-1, and had we kept them on anti-PD-1, that may have happened anyway. But I don't think that we can just turn around and reassure our patients that because you had a CR the first time, don't worry, we'll just put you right back on and you'll do great, okay? Our data would argue that that is not the case. So what about IPI plus Nivo for melanoma? So this is the Checkmate 067 trial, seminal work done by my mentor, Jed Wolchuk, and many others. That defined IPI plus Nivo and led to the approval of this combination for melanoma. And we know actually from this trial, this was the 6.5-year update published in JCO in 2022, that the median duration on treatment here was 3.6 months. Okay, and many of these patients weren't stopping because of CR, they were stopping because of toxicity, right? This is a much more aggressive treatment with a much higher rate of toxicity. But you can see here that the median treatment-free interval is 27, almost 28 months. I, for the sake of time, didn't compare this to single-agent PD-1. This study was not powered to do that. But if we look at the data, right, the treatment-free interval here is actually much longer for for combination ipilimumab plus nivolumab compared to single-agent. And so you can see here 77% of the patients at this 6.5-year follow-up that had a complete response were still treatment-free. If we break this down by the CRs and PRs, you can see at the 5-year mark, 81% of patients still in CR that had a CR were still progression-free. 79% of the PR group. That PR group goes down for nivolumab some, but the CRs still look quite good. So when we're thinking about discontinuation, I think many of us should feel really reassured about CRs and still pretty reassured about deep PRs. But those stable disease patients, I think we all know that we need to worry about. So what about using a biomarker to direct stopping treatment? So in this case, this was a single center study of about 100 plus patients, 120-ish patients, who had who discontinued treatment for either complete metabolic response on a PET that was confirmed on 2 subsequent PETs versus patients who discontinued for toxicity. And you can see certainly that patients who have a complete metabolic response at the 24-month mark, so 2 years, have a 96% progression-free survival. Most of these patients had discontinued at the 1-year mark, so at a year off of treatment. These patients were doing quite well. Similarly, Jeff Gibney from Georgetown published a very similar series doing a PET at 1 year and discontinuing treatment in about 122 patients with a planned discontinuation if a patient had a negative PET and or if they had a positive PET but the biopsy of a positive lesion did not show active disease, right? Knowing that there could be immune activity there that could be leading to PET positivity. And you can see that those patients here in green, again, had excellent event-free survival, well above 90% at 3 years. So that led to the development of the PET Stop study, which is an ongoing study currently accruing across the cooperative groups, where they are taking exactly this approach. This is patients with advanced unresectable or metastatic melanoma. At 1 year, doing a PET scan. If the PET is negative, discontinuing treatment. If the PET is positive, doing a biopsy. If that biopsy is negative, they still discontinue. This is a single-arm study, non-randomized, simply following these patients to gather some data. There was an attempt at looking at this beyond melanoma using this meta-analysis, the OTHERS study. This was like 22,000 patients across almost 60 studies. And what you can see here is mostly, I'm just going to say that the confidence intervals are really big. I don't think we can draw any big conclusions here. They looked at non-small cell lung cancer, at renal cell carcinoma, melanoma, and head and neck, some of the most common cancers that we have some long-term survival data with immunotherapy. I don't think there is any strong signal that we need to continue treatment long-term, but most of all, just these confidence intervals are just really large. And I'm going to argue that I just don't think that retrospective data is the way that we are going to answer this question. There was one prospective study that has read out in this space, Checkmate 153, which was a prospective trial in non-small cell lung cancer. This took patients on single-agent nivolumab who were treated for 1 year, randomized them to either stopping at 1 year with allowance for retreatment at the time of progressive disease or continuing nivolumab indefinitely. And the continuous arm here is shown in blue, the 1 year fixed duration shown in red. And if you look at progression-free survival, even in the CR/PR group, you can see that there was actual clear superiority for continuing treatment at least beyond 1 year. Okay, now again, that didn't look at 2 years versus stopping. That didn't look at any biomarker. This was just a planned stop at 1 year. But this certainly raised concerns about, just routinely stopping treatment in all patients without a biomarker-driven approach. But it is the only prospective data that we have, at least that has read out in any large form, and certainly the only randomized data that we have. So something that warrants conversation with our patients. There are several other prospective trials ongoing at this point. We lost that, but I think they switched it over to a different talk, but, Sorry, I'm almost done, I promise, but I just want to highlight a couple of trials because I think they're really important. So STOPGAP is a Canadian randomized trial treating to maximal clinical response, so confirmed response on 2 scans, versus 2 years planned on treatment with an overall, primary endpoint of overall survival. That's 600 patients, randomized study, as I said. PET Stop we discussed. Dante is a study in the UK looking at stopping treatment at 1 year versus continuing treatment for 2 years with a primary endpoint of PFS. That's 1,200 patients, so I think this will be likely, if and when they can ever finally accrue to it and finalize it, I think this will be the definitive study, at least in melanoma. And then the Safe Stop trial is a smaller single arm, similar to PET Stop, that's being done in the Netherlands, that you stop treatment at CR or ongoing if there's a PR. And with that, I will just say that I think this is an open question still. I think I probably raised more questions than gave you answers. At least in melanoma, I think there is unlikely to be considerable benefit of treating beyond 2 years. We have excellent outcomes for our patients who are continuing to have a complete response at 2 years. I feel strongly that retrospective studies are unlikely to give us the answer here, and that we need prospective and preferably randomized trials to guide this decision-making, and particularly radiographic or biomarker-driven studies to really help us pick the right patients. And with that, I will say thank you.
Thank you very much, Allison. I hope that somebody during the panel will ask Allison how the circulating tumor DNA is being incorporated into these various, I call them all PET stop studies. Our next speaker is going to be Dr. Katy Tsai from UC San Francisco, and Katy will be speaking about something that is her specialty, which is short and particularly long-term toxicities of immunotherapy for cancer. Yes? And then you'll be stuck with me, but I promise I'm going to make my talk quick, and we are going to be on time by the end of lunch.
All right, good morning, everyone. Thank you all for being here today. I'm just going to get situated here in terms of advancing my slides. All right, so I am a melanoma oncologist and clinical researcher over at UCSF. And as, sorry, in terms of advancing the slides, that is... I am pushing. Yeah. Oh, there's a pointer. Thank you. All right. Thank you for that. Okay. I've got it now. I'm good. So these are my disclosures. And, now that we have a graduate level degree and a postdoc in tumor cell immunology, thanks to our previous speakers, I really won't spend too much time on this. We already heard earlier from Dr. Margolin and others about how immunotherapy and specifically immune checkpoint inhibitors work to affect anti-tumor immunity. Broadly speaking, and again, this is a gross generalization, but we learned earlier about how anti-CTLA-4 antibodies work more proximally at the level of T-cell education. We have their proliferation of active T-cell clones that can presumably migrate onto the tumor microenvironment to kill off cancer cells. And then, of course, anti-PD-1 or PD-L1 antibodies are felt to work more distally, reinvigorating T-cell activity within the context of the tumor microenvironment. That preclinical work laid the groundwork really for a series of trials afterwards, and the subsequent FDA approval of multiple immune checkpoint inhibitors. As Dr. Betof Warner mentioned earlier, really it all began in 2011 when ipilimumab, or IPI, an anti-CTLA-4 agent, was approved for the treatment of advanced melanoma. And subsequently, the PD-1 antibodies, Pembro and Nivo, also approved for the same indication, advanced melanoma, approved a few years later in 2014. If the chart on the left is hard to read, that's by design. So really you can see here how over time, so in years on the y-axis, you can see multiple checkpoint inhibitors here indicated in the legend and also by these colored dots, have been approved for multiple cancer indications indicated here on the x-axis. And so it's a bit of a dizzying array here. In an attempt to make things a little bit more legible, you can see on the right-hand side approval of, or FDA-approved current immune checkpoint inhibitors for various indications, including the fairly recent approval of relatlimab plus nivolumab for the treatment of advanced melanoma. So, certainly the clinical benefits are, I think, not to be argued with. We have certainly seen long-term survival. We saw the survival curves in the previous talk. Here is just a tabular kind of representation of long-term survival. So, progression-free overall survival benefits at past 4 years, not just in melanoma, but now in multiple different cancer types. And I think along with that really we have to realize that maybe this is more impactful in terms of actual numbers, that if you think concretely what this improvement in survival translates to in terms of numbers, you can see here on the right-hand side, I put in some data from the American Cancer Society. Here, over a 10-year period, so in a relatively short period of time, there's this estimated projection of an increase in 30% of cancer survivors, and that's just in the United States. So I really think it's incumbent upon us to think about, we can't help but wonder, well, how is this going to affect the healthcare system? How can we best equip ourselves to take care of this cohort of cancer survivors? Now, of course, all kinds of things to consider, financial toxicity, stress on the healthcare system, et cetera. But really, when I talk about taking care of cancer survivors, part and parcel of that, of course, is taking care of any therapy-induced side effects. These immune-related adverse events, or IRAEs, as we refer to them, I probably don't have to tell this audience that IRAEs can be incredibly wide-ranging, and their presentation really affects on the particular organ system that gets affected. This is a non-exhaustive list. It looks a little bit probably stressful just to see the variety of symptoms that can present. Some of these are more common. I think certain dermatologic presentations and diarrhea/colitis come to mind, although certainly on the rarer end of the spectrum, we have here, including but not limited to neurologic toxicity, cardiovascular toxicity, among others that you can see here. So why do IRAs happen? And Dr. Margolin, I think you and I were probably in simpatico because I'm showing the same slide or same figure that you did earlier, so glad to repeat it just for some additional recognition here. So, I think the brief answer here is that really these side effects come about from T cells that are triggered by removal of immune checkpoints. But I think, the exact mechanism probably depends on the organ system that is affected. I think the answer is probably going to be different for each organ. For example, you can see here that activation of tissue-resident memory cells that's been implicated in certain models of ICI colitis, for example. Increasing levels of inflammatory cytokines. Certainly we see that in ICI colitis, but also in certain forms of cutaneous IRAEs. Increasing levels of pre-existing antibodies that's been implicated in certain endocrinopathy, specifically thyroiditis induced by immune checkpoint inhibitors, and also increased cross-reactivity of T cells in healthy tissue versus tumor cells has also certainly been described, for example, in myocarditis. What this model doesn't include are potential tumor extrinsic factors. So for example, thinking about genetics, impact of microbiome, those are also probably important, although certainly we have a pretty fuzzy sense of, I think, how those contribute at the moment. So how frequently do IRAEs happen? The effects that this breach of self-tolerance, I think, are felt, as you can see here, more acutely when we use combination immune checkpoint therapy. As you can see here outlined, and this is taken from Checkmate 067, which is a big phase 3 study treating advanced melanoma patients with combo ipi-nivo versus nivo monotherapy versus ipi monotherapy. And you can see here that the frequency of treatment-related adverse events, as well as treatment discontinuation due to said adverse event, were really higher in the combination arm than either the ipi or nivo monotherapy arms. And then, of course, so we have some sense of frequency of IRAEs, but in terms of kinetics, when do these IRAEs happen? And the trend is similar here, where you have monotherapy. If you kind of look at these charts from top to bottom, you get the sense that severity or toxicity grade, which is the y-axis in all of these, and time to onset of IRAEs is increased in the combination arm rather than in the monotherapy arms. Taking a step back, you can also see some general trends illustrated by these charts. For example, that in general, IRAEs tend to happen within the first 3 months of treatment. However, delayed and chronic presentations of IRAEs are also possible. So in terms of management of IRAEs, or really I think this table seems to describe more acute presentations of IRAEs, that has been described by several important professional society papers, and kind of the general consensus I think on how to manage that is outlined in this table here. I think the one thing that strikes me as I look at this is that first of all, this is a rough rubric. I think certainly there are always patient-specific factors that will change things, but things also haven't seemed to change very much, right? When I was a medical resident, I don't want to say how many years ago, but probably 10 years ago at this point, we were bombing people with steroids. And steroids do have value. I'm not saying that we shouldn't use them, but I think that, particularly with regards to severe, grade 3 or 4 IRAEs or with refractory toxicities, I think that there's still quite a bit of room for improvement in how we manage them. For example, when should we use immunosuppression? Is earlier, in fact, better? Which immunosuppressive agent should we be using? And again, as I mentioned earlier, steroids can play an important role, but I think it's worthwhile to take a step back and think about what exactly we're doing when we give people steroids. So glucocorticoids and the glucocorticoid receptor, they inhibit inflammation through non-genomic and genomic effects. Inflammatory pathways are characterized by positive feedback loops and by multiple redundancies, as you can see in this figure here. And the glucocorticoid receptor inhibits these pathways at multiple points by directly blocking transcription of inflammatory proteins activated by NF-kappa B, also by inducing the expression of anti-inflammatory proteins such as MAPK phosphatase and annexin-1. And while those can be effective, I think it's important to acknowledge that high doses and or prolonged doses of glucocorticoids can have pretty serious side effects. I think that these have implications in a cancer survivor population, not only in terms of managing side effects, but also kind of questionable impact on cancer outcomes. I know that's a bit of a controversial topic, and to be clear, I do think that there's a difference between kind of high dose early use of steroid versus maybe lower doses that are used later on in the course to manage a lower grade IRAE. But still an important question to acknowledge, right? And certainly a lot of patients will express concern about this, that, oh, I don't want to use steroid because I think it's going to impact my anti-tumor efficacy of the drug I'm taking. So data is a little bit mixed in this area. I think that on one hand, in a series of almost 1,000 patients who received PD-1 therapy, that you can see here that those who did receive steroid indicated in the darker line that progression-free survival and overall survival was adversely impacted. However, on the other hand, if we look at other series, for example, on the left-hand side, this is a cohort of advanced melanoma patients treated with ipilimumab monotherapy, that in that case, those who received steroid in yellow versus those who did not receive steroid in blue, that it seemed like overall survival and time to progression were not impacted. On the right-hand side is a different series. So this is taken from Checkmate 067, actually, where patients with Ipi/Nivo, who received Ipi/Nivo, they did a subsequent analysis where they looked at survival parameters in those who had to discontinue Ipi/Nivo due to toxicity compared to those who did not have to. And you can see here that the PFS and OS remain relatively preserved between the two groups. So again, a bit of a mixed bag. My takeaway from all of this is that steroids, important role, especially in very severe acute toxicity, but certainly we can't rule out that they may be potentially blunting efficacy, especially at high doses and when used early in the course of treatment, and of course, trying our best to avoid all the different kinds of steroid morbidity that can happen. So as patients are living longer, I mean, I think it's always been an outstanding question as survivorship has improved as to whether delayed or chronic IREs can happen, and if so, what does that look like? That's been challenging to define, I think, for a number of reasons. For example, follow-up of immunotherapy-treated patients being somewhat constrained in the metastatic setting. Symptom attribution can be difficult in the setting of multiple other comorbidities, including the cancer itself. But there was a retrospective study by our colleagues over at Vanderbilt in melanoma who tried to put some parameters on figuring this out. So these are pretty arbitrary definitions as outlined in this particular analysis. Ultimately, I do think there needs to be some sort of multidisciplinary consensus on these standard definitions. But at least for the purposes of this paper, what they did is that they defined delayed IRAEs as those arising within 6 months after treatment cessation. Chronic IRAEs were defined as those extending at least 3 months after treatment cessation. And this was a cohort of about 318 patients who received, melanoma patients who received adjuvant PD-1 therapy. And I think if you look at this flow sheet, you can see, the 318 patients. What I find striking is that, there were 53 patients who did experience a delayed IRAE, and then a pretty, significant proportion of patients, 46% of the original cohort, who did develop what they defined as chronic IRAEs. In terms of better define, this raises so many questions, but one of them is, well, did people with these chronic IRAEs resolve? So on that front, the initial paper that these authors put forth described that 14% of these patients had resolution of their chronic IRAEs. That's a pretty low number. Somewhat more encouragingly, in the subsequent report with longer follow-up, so with 18 months of follow-up, they had an increased proportion, 35%, who did have their chronic IREs resolve. So definitely encouraging, but I think still, again, raises more questions really about the mechanisms of these chronic IREs and how we should be treating them. In terms of what these chronic IREs were, I think not surprisingly, the majority of them were endocrine-based, so 58% were an endocrinopathy. But if you look at the blue, so it was kind of interesting to see what was described as non-endocrine toxicity, so 52%, which is not a low number. And out of kind of personal interest, it was interesting to see that dermatitis and pruritus, also colitis, diarrhea were on this list. With a focus on dermatitis and pruritus, which despite being often low-grade, can definitely be detrimental, at least in my patient population, to daily quality of life. And there has to be a better way, I think, of treating these besides chronic low-dose steroid. So, work is ongoing and needs to be ongoing in this area. I just wanted to highlight this presentation from SITC just a couple of weeks ago, where a group out of Sloan Kettering with colleagues in Colorado put together a prospective study doing skin tape and plasma cytokine analyses together with biospecimen analysis of more than 200 patients who did develop a skin IRAE compared to those who did not. And you can see that they did some work correlating the clinical phenotype with certain inflammatory pathways. And the author's thrust here was basically, can we target these inflammatory pathways in a more rational specific way rather than using non-specific steroids on a long-term basis. And then last but not least, I am really lucky to be able to partner with my colleague, Dr. David O at UCSF, in co-directing an immunotherapy toxicity clinic. We have a great collaboration with all of the medicine subdivisions, but I'm just highlighting here some work that he's done with our UCSF GI group. Dr. Margolin talked earlier about kind of granzyme B expression in effector T cells, tissue-resident T cells. So they've done some work along with others, nationally to show that checkpoint inhibitor colitis is different in terms of what we're seeing as the driving effects here. But I think what this also highlights, and hopefully what this talk has shown, is that really we are sorely in need of better biomarkers, also better tools to try to detect early toxicity. And even though, I'm not, of course, biomarker work is important, but kind of with an eye to thinking about what's accessible to people in the community or readily feasible, intestinal ultrasound, for example, or just thinking about, less invasive and better tools to detect things like ICI colitis, we are looking into applying intestinal ultrasound as a very quick, non-invasive way of diagnosing and following these patients. So, in summary, I think this is ongoing work. We know some things, we don't know a whole lot still. And it's really exciting to see data being progressively generated for more selective immunosuppression, as well as better prognostication. So I will leave it at that, and I want to thank everyone who's been involved with the site clinic at UCSF, which is our Cancer Immunotherapy Toxicity Evaluation Group, especially Larry Fong and his Cancer Immunotherapy Group for supporting that work. Thank you.
Thank you for that, Katie. That was very informative. I learned. Oh, is this your phone? Your kid's adorable. Okay, you're stuck with me again. As I warned you, I'm going to go really fast through this talk about brain metastases. Greg, are you next? I thought I was next. I am next. So where's my talk? Do you have my talk? The brain, there we go. Okay, fantastic. Thank you very much. Okay. So I'm qualified to do this because I've loved to hate brain metastases from melanoma for many years, and you'll hear about some of the work that I did and those of others. But I'm going to try to catch up with time a little bit. As many, if not most of you already know, melanoma is the malignant disease with the highest incidence of brain metastases. The highest prevalence of brain metastases occurs in people with lung cancer and breast cancer, because those diseases, of course, are far more common, but their incidence of brain metastases is lower. So that if you're looking at, in the original work on brain metastases, trying to learn about biology and radiation therapy, one had generally 3 tumors: melanoma, lung cancer, and breast cancer. And then there's a small smattering of others. And then there are those that almost never go to the brain, like prostate cancer, rectal cancer, for example. Rare variants that present in the brain only are presumed to have come under immune control in other parts of the body. And that's kind of mysterious, and we won't really go into that. Historically, the median survival for patients with brain metastases for melanoma was only 4 months, and you'll see some better numbers coming along. Just a touch of biology about how it reaches and thrives in the brain, which is a topic of a great deal of investigational work right now, and nobody really knows, is actually better shown in this pictorial slide from Mike Davis's group a little over a decade ago, which essentially, it's a little hard to follow the slide, but basically it raises the questions of whether brain metastases come from clones that were born with the original melanoma, whether they got that way somehow on the way, whether they got that way from other brain metastases, and many of the different possibilities are equally possible, and I think we're going to have better answers in the next few years, but we don't really know quite yet. Other than that, brain metastases in many of the models follow sort of the Isaiah Fidler model, which is that if you were to take metastases from a particular organ and then reintroduce them to an animal, they will tend to go to that same organ in the new animal. And so there's definitely a degree of sort of organotropism to these metastases as they go through their life cycle. Another area of elegant work that's being led by Priscilla Brastianos and Scott Carter at the Broad Institute in Boston is this concept of branched evolution. Again, everything that happens in cancer is quite Darwinian in nature. There are mutations and there's selection of the fittest. And so what you see is actually some degree of clonality, which is that if you look at, and this isn't true just for melanoma, but if you look at let's say a driver mutation like BRAF, and then you look at metastases in the lung, they may have a secondary mutation, and all the lung metastases will have the same secondary mutation, suggesting that's a clone, but the ones in the brain will be different from the ones in the lung, but they'll be the same as each other. And the ones in the intestine, let's say, will be the same as each other, but not the same as the ones in the lung or the brain. So a lot of selectivity between kind of seed and soil, if you will. Let's skip this slide. It's got a lot of complicated interactions in small font, and it kind of, reproduces what we were talking about earlier in any case. And similarly, here's a complicated slide that just reminds me to mention that in addition to some of the immunologic things that we talked about, there are other controlling factors that relate to gene regulation, gene expression regulation, such as the hypoxia axis and those molecules that are elaborated under the transcriptional control of agents like, of molecules like HIF-1 alpha, such as vascular endothelial growth factor, platelet-derived growth factor, and fibroblast-derived growth factor. So those may become, or they've started to become part of the therapeutic armamentarium as well against brain metastases. So the next few slides just come from what was a very, very elegant paper that was published in Cancer Discovery about 4 years ago. I was lucky enough to co-author the editorial to that, which was written by Colt Eggleston in one of the immunology labs at City of Hope. And this was a characterization of several of sites of disease ranging from the primary through the extracranial metastasis and into the brain metastases from varying numbers of patients, and a number of omics studies was done, as you see on the right lower side of the slide, to characterize these metastases. And basically, a kind of summary of this whole thing was to show that genes that were associated with immune infiltrates in the tumors were correlated with survival, and the one that was least correlated in a favorable way with survival was the presence of transcripts that denoted neutrophils. And we know, and I'm sure many of you know, that in the circulating blood, one of the sort of dynamic parameters that goes along with the response to therapy is the neutrophil to lymphocyte ratio. When it's high, it's unfavorable. When it's low, it's favorable. In sort of an independent way, but as for so many biomarkers, it's not enough, and you can't use it at the very beginning either. So it's more of a dynamic than a predictive marker. There's a little bit of the metabolomics that I mentioned to you earlier. I'm not going to dwell on that, or we'll never finish. But this was a very nice picture that Colt made for the editorial that showed that as the tumors go from being extracranial metastases to intracranial metastases, you lose some of the T-cell infiltrate, the dendritic cells, the macrophages. The metabolism switches from more of a glycolytic to an OX-phos picture, and that can actually be intervened with or targeted by certain inhibitors of oxidative phosphorylation. They had a mouse model in their paper that was very nice, but unfortunately so far it was with a drug that couldn't yet be used safely in human beings. This is an old paper now from about 2012, but I love to quote this paper in talks and writing. This concept of capture, crawl, and cross we all know, or at least we think that in terms of a relatively intact blood-brain barrier, that large molecules like antibodies to immune checkpoints probably don't get into the brain very well. Of course, we know that the blood-brain barrier is somewhat permeabilized, at least in some areas, at sites of tumor. But it's thought that it's far more likely that the T cells that are doing the job that you'll see in the next few slides against tumors in the brain on an immunologic basis are probably becoming sensitized outside the brain, and then they, because of this flexibility and this crawling and crossing and squeezing through this semi-permeable membrane, is really what's happening in terms of successful immunotherapy of tumors growing in the brain. So my favorite phrase is to really tell people that it's not, some people use this term melanoma brain mets, MBMs. I think it's disrespectful to the patients and the disease and the research, and it's really, a matter of melanoma patients with brain metastases, because they almost always have extracranial disease as well as their brain metastases. Sometimes they're disparate in terms of their reaction or response. For example, a patient who develops brain metastases may be developing it as an escape from control extracranially, although that's not very common. So just the principles of clinical therapy are that whole brain radiotherapy is essentially ineffective in brain metastases from melanoma. It's useful for breast and lung because those diseases are more sensitive to radiation. However, stereotactic radiation is very, very good against melanoma metastases as long as there aren't too many of them. Resection is used generally if it's required diagnostically, if there's a sudden bleed, if there's a mass effect or a neurologic deficit that can be potentially reversed by removal of the tumor. And then usually the stereotactic radiotherapy is used to the surgical bed and then to any other small metastases that may be in place. Historically, patients have been excluded from trials, and so it took a long time before we either had A, effective agents, or B, the trials that were required to know that they were effective. But finally, the first out of the box was a study that I led with the cytokine working group a number of years ago, a decade ago, using ipilimumab, which was the only drug we had available at that time. The responses were occurring about as often in the brain as they were outside of the brain, and the survival curves looked like ipilimumab survival curves look in patients without brain metastases. We moved on to be able to study single-agent PD-1 blocking agents, and this was a study that was done led by Harriet Kluger and her colleagues at Yale, and showed a little bit better outcomes. Again, mimicking very nicely what you'd expect to see in the extracranial sites of disease. And then the last study that I was involved in leading or co-leading and being the senior author for was shown in the right side, and it's shown against the same study that you saw, I think, in some of the earlier slides with the BMS 067 trial, or we'll call it the 067 trial. We're not supposed to mention the company. Ipi and Nivo versus Ipi. And what I wanted to show in this slide is that our long-term progression-free survival curves, which look like the survival curves in asymptomatic patients not on steroids, actually, if anything, they look slightly better than what was done here. And I would venture to guess that that was because we were treating highly selected patients in those trials with very small, very limited numbers of brain metastases, not on steroids, good performance status, and usually very small amount of extracranial disease as well. And this is kind of backwards because this is the study design. It's not that important to go over that. Responses were in about 55% of patients, which is exactly what you get with ipilimumab and nivolumab, at the cost of around the same rate of severe grade 3 and 4 immune-related adverse events. So it's not trivial kind of therapy. Here's the overall survival at a plateau of about 72 or 3% long-term. And this is from some other trials that were done with the same agents and basically showed the same kind of results. remaining questions include what to do with patients who have symptoms and or who are steroid dependent. I don't know the answer. There are going to be some combination therapies. There may be some some steroid-sparing approaches like bevacizumab, for example, or careful sequencing or combinations with radiotherapy, which is being studied by the Melanoma Institute of Australia group. This statement was made by Georgina Long, who's kind of the queen of melanoma from the Melanoma Institute of Australia, at a recent meeting, which is that you might say at this point that the blood-brain barrier is really not a barrier and that the brain is just another site. We don't have to be quite as afraid of it as we were in the past, excluding patients from trials, excluding patients from therapy, et cetera. But we still have this adversary being the steroid-dependent and symptomatic patients. So as you can see, we've seen what the unique features are that support initial systemic therapy. We scan patients a lot now, so we pick up the metastases when they're small and asymptomatic, thankfully, and everything else I think I've already mentioned. So I'll stop there. I'll thank you for your interest and attention. I like this slide because progress in this area helps to light up the pleasure centers in the brain of scientists who work here in this area and help our patients live longer and better. And the next speaker is Greg Daniels. And Greg's at UC San Diego, and he's going to be speaking about also something that's a little different than what you normally talk about, which is immunotherapy of solid organ transplant patients with autoimmune disease, or those with autoimmune disease.
All right. Hey, thank you, Kim. And thank you, MOASC and ANCO, for putting this on and inviting us here. I actually, if you see my topic, it had another subtitle on it too, in patients, I think, with autoimmune diseases. And I decided that's just too much for 15 minutes. I can't do it. So I'm going to talk about solid organ transplant patients. And I realize I don't have a disclosure slide, and that's because I don't have disclosures. I work at the university. I don't have any sponsorships otherwise. So next slide. Oh, me. I should know that. The green. You know, it's so obvious. Okay, so what am I going to talk about? As I said, solid organ transplant and why we should know about it. I'll talk about the background in terms of how many patients are out there and what they're experiencing. And then where are we with the use of immune therapies in solid organ transplant patients, and what we don't know, which is a lot. So, green arrow. More and more patients are getting transplanted. The source is usually unfortunately, a deceased survivor or deceased organ donor. And last year we had over 42,000 transplants in the US. It's in an age group that also catches the attention of cutaneous oncologists, so older men, and there are a lot of people wishing that they could get on the organ transplant list, and there are more than 100,000 waiting. So the incidence of skin cancers in organ transplant patients it rises over time and with the depth and type of immune suppression that's there. So really, you can do a big favor to patients by getting them in with dermatology early. The way that we should be dealing with this is prevention, early detection, prevention, primary prevention. You'll see there that in organ transplant patients, approximately an increase of 100-fold for the age-adjusted patients. And again, this increases over time. But squamous cells are the ones that are promoted the most, Merkel cells second, basal cells, and finally we get down to melanoma. Now certainly there are other types of cancers that happen in solid organ transplant patients, and one of the main causes of death in a solid organ transplant patient is cancer. So, and there's some other ones listed. Just briefly, you've seen a lot of slides about, say, how glucocorticoids work. I put up something very simple there. They decrease cytokine production. Azathioprine, not used very much anymore because we know that that causes a lot of toxicities itself. And we've moved on to other things, cyclosporin still used. And I list off the mechanisms because, we talk about immune suppression. Obviously, just like immune stimulation, there's a huge difference between CTLA-4 stimulation and PD-1 stimulation, consequences for memory, things like that. Same thing on the immune suppression. And we know now that it really does matter which ones we use for cancer incidence and outcomes for patients. One of the earlier studies, I think to hammer this home, this New England Journal paper looked at kidney organ recipients, and they had to have had a history of squamous cell cancer. At that event, they were either randomized to go on to sirolimus, so an mTOR-based suppression, or they were continued on their calcineurin inhibitor. And you'll see there just pretty clearly that in this randomized study that you had less cutaneous squamous cells coming up in this group. So we get to, and I'm a clinical guy, by the way, so we're going to talk just clinic. So this gentleman had a polycystic kidney disease, eventually needed a transplant. 2 years after that, started popping up skin cancers, and as usual, was aggressively managed with surgery and ultimately radiation, multiple surgeries, more radiation, until finally, better go see the medical oncologist. So met him, and his PET scan showed just what the picture showed, just a lot of disease. He has nodal disease, and he had also a lung metastasis. So what can we do for this? Okay, cetuximab. Cetuximab or cytotoxics are certainly an option. Depends on the transplant, right? Because you wouldn't want to use cetuximab in a lung transplant patient. That leads to bad outcomes and death. But for a kidney transplant, you certainly could use cetuximab. You could use cytotoxic chemotherapies. So we chose to put them on study. And this was presented at SITC, and it's a intralesional therapy that I think Dr. Hemilowski is going to talk more about in a little bit. But like Imlygic or TVEC, it's looking at an oncolytic herpes virus in patients with any kind of cutaneous cancer who have immune suppression from solid organ transplant. So just like Imlygic, oncolytic herpes virus with a transgene for GM-CSF, but this variant also has a protein from a simian virus, this GALV protein. Very interesting what it does. It can cause syncytia formations, so it's expressed and causes things to kind of just lump together. That syncytia formation is really immunogenic, and it may be part of the mechanism of this. So this study looked at, again, initially just kidney transplant patients as well as liver, and recently expanded into other transplants such as cardiac transplants when they initially showed some safety data. So transplant patients coming in once every 2 weeks for intralesional injections of this oncolytic herpes virus. And you'll see there the type of tumors that are initially reported in the SITC cutoff, and most of them were cutaneous squamous cells, some Merkel cells. And as usual, they're older, mostly men that are getting this disease. So what are the type of responses that you see? Just like Imlygic, if you can inject it in there, you're going to get some killing. And so most of these patients are localized tumors like the one I showed you. There were metastatic, but metastatic in this trial was defined as even regional lymph nodes. So the patients that had response are listed as cutaneous squames and Merkel cells. And on this slide gives you an idea of the duration of responses so far seen. The top one is a cutaneous squame that is still ongoing. A couple pictures to just illustrate the type of disease that was being dealt with on the study. Either it could be injected with ultrasound if the lesion was a little bit deeper, or these superficial lesions. Very well tolerated. Again, similar to TVEC or MLIGIC. You might have a viral syndrome for a day or two, but grade 3, 4 toxicities were pretty low. So went on study, didn't work, right? Unfortunately, that's how it happens. While the tumors that I was injecting did necrose, I could never get ahead of the advancing edge of the tumor. And so options, back to cytotoxic chemotherapy or cetuximab, but he decided he was ready to get rid of his transplant. And so what that is anticipating that if I give him anti-PD-1 therapy, I will get rid of his transplant. So he started cemiplimab, had almost an immediate response. His pain got better. He just felt a lot better. Everybody was happy. And then just prior to his third dose, you'll see he lost kidney function. It actually was pretty quick. He was fairly sick, high fevers, felt horrible. So we sent him to the hospital as his kidney necrosed. Gave him steroids and averted that kidney loss. And one of the reasons we decided to do that was, well, he'd had a nice clinical response. We thought, well, we got this far, maybe we can keep that kidney there. And his creatinine recovered somewhat. And he got about a year of disease control from that event. Until his neck was progressing, it progressed in such a way that was not surgically resectable. And our radiation therapist gave him a course of palliative radiation that didn't last very long. You'll see his open wound there. So, well, that what to do next is off to ASCO. So this year, Glenn Hanna and Ann Silk presented a small set of data where this had been tried. You know, there's case reports out there of giving PD-1 therapy or combination therapy to transplant patients, and really hasn't worked out. They'll say, oh, look, there was a response, but everybody lost their graft. Or look, it was safe, and nobody responded. So trying to find that sweet spot where we can have enough immune suppression to keep the graft, but you know, is there a window where we get an anti-tumor response? And so what they did was switched everybody, going back to that graph I gave you of different mechanisms, but everybody was switched to an mTOR inhibitor. And once they were established at that, they got their anti-PD-1 therapy with, for some unclear reason, pulses of prednisone. So you would pre-pulse them just before the anti-PD-1 therapy, and then you'd get them back down to a baseline of 10 milligrams. And in their data that they presented, which he just emailed me after I told him I was presenting this, he said, oh, good news, it's going to be in JCO soon, so you can check this out. That half the patients responded and everybody kept their graft. So that's enough to prompt a large cooperative group study that's in progress, or getting going, or in somebody's mind at least. So what happened to this gentleman? As I mentioned, I didn't go to ASCO, but I always do the virtual meeting. Saw his presentation, and with his this patient's clinical progression of pain, we decided not to do cytotoxic chemo, which again would have been a choice, but to go ahead and give him anti-PD-1 therapy. And just say, as of yesterday, he is having improvement in his pain, and so far is keeping his graft. So that's just some pictures of his neck. So how do we deal with these? Again, I just want to go back to, it would be great not to deal with these. And so dermatology, decreasing risk factors, these are really the way to deal with this disease. Because this cancer is a huge burden in these chronically immune suppressed patients. And you need a dermatologist that's going to follow them as an immune suppressed patient. And so somebody who wants to do pretty aggressive prophylaxis and early treatments. You want to get them on the lowest effective dose. And I don't know why it's so hard to coordinate with the transplant docs on this, but need to just rattle their cage a little bit. And personally, I think everybody should be at least tried on an mTOR to see if that's tolerable for them. Not all patients tolerate it. So there's so much unknown. We keep thinking that maybe we've solved cancer. Well, we haven't. And this is an area where we really could do a lot better. So we talk about all the checkpoint antagonists, but one could really use checkpoint agonists or other things to keep a graft in place. There's so many other strategies that should be explored here that I think is ripe for science. So again, I just want to say prevention's best strategy. Work with your dermatologist. Even when they start to come into medical oncology, you got to make sure that they're seeing dermatology. And do I dare say you can use checkpoints, but just be ready for the graft to go away. And maybe there's a window here with this kind of approach, but I would urge extreme caution. So that's where we're at with, I think, immune therapies in solid organ transplant patients. 3 seconds. So I want to invite all the speakers back up because now you guys get to ask questions. Thank you.
Katy, Allison, and Anna, and me, and Greg. And I think the way it's we're supposed to be able to see the questions on the iPad. So maybe I'm supposed to stand here and read them or something, right? Should I just stand here and read the questions then? There's one. Oh, is there just one? Okay, that'll keep it. That'll get us back, and then we'll have a break. But let's try to keep it to around 10 minutes. Okay. So, does it show on here? Oh, questions. Yeah. Here it is. Okay. Okay. There are two now. Okay. So. The first one would be directed at me, and it came in a while ago, and it says, would I recommend whole brain irradiation for patients with seizures secondary to diffuse brain metastases? No, I don't think I would recommend whole brain radiation for that purpose, but let me think about this for a second. So it's like a two-part question. With seizure, you have to control the seizure. And it's true that there are times when there's blood as a result of a highly vascular tumor, which is what melanoma is. The other tumors aren't quite as vascular. Seizures are not very common, but certainly if you have cortical involvement, you can. You can usually keep seizures under control with medication. The use of whole brain radiation for people with diffuse brain metastases, of course, we may be stuck with that as our only option, but those patients are the ones who have the 4-month or less survival duration likely. They will often need to be on steroid to control things, particularly, again, if you're trying to control seizures, you got to pull out all the stops. And then whole brain, you know, if that's your only choice. I would always look for 1 or 2 or 4 or 5 foci that I could also treat with stereotactic radiation. You know, if there's diffuse small lesions, use the whole brain, but then sort of boost with SRS. I think that's all for that one. And then the other question, I think will go to Greg. Are there any data to estimate the of graft failure after IO is given to a patient with a malignancy in the setting of a solid organ transplant?
Yeah, so I think one thing that people are doing to monitor, right, for graft rejection, you can monitor for circulating DNA and certain signals. So I know in the trial, they're using that as a biomarker to adjust. Yeah.
So I think, I would just bring up part B to that, and then we can break for a short break, which would be, oops, there are more questions. There are other organs that are transplanted that we cannot live without. And so, what happens when the patient with a heart, a lung, a liver, maybe even pancreas, comes in with these malignancies that you would otherwise want very much to give IO to?
Clinical trial.
Yes. Okay. Well, that's always the answer anyway. Okay, there's just one more question, actually. I believe that this question is probably better discussed during the break because it's too large and diffuse to really answer in this context. I'll just read it just so you know. How do you believe artificial intelligence will impact this field? Has your institution embraced this technology? I mean, unless somebody really wants to take a shot at that, I think that's probably more for individuals.
Yeah, I think, yeah.
Oh, all right. Takiao's going to take a shot at it.
I will say, I'm not speaking to speak, but I'll say,
Speak loud so everybody can hear you. Or else come up. You can come up.
and I assume this is for any of the data that was discussed during the session, and the AEs, in response. And so there are a lot of new computer algorithms that can surf directly from Epic. And they're getting pretty sophisticated. I think one thing that's new that we didn't have before, like before you could definitely read and recognize things and sift them out. And that obviously then enhances the cohort that you can look at. But now there's also the input part with ChatGPT that you can do that. So I think the bottom line, I think, we'll have more and more real-world data to sort of verify some of the things we've seen on study, which I think is really important because, I think studies are not going to look, we're going to start having patients 15, 20 years out from some of these events and these issues, recurrence or toxicity. And so I think that hopefully is very exciting.
Yeah, and that,
totally
in fact...
agree.
Oh, go ahead, Katie.
Yeah, I totally agree with that, and I was just going to hop in that thinking of the folks who are involved with our immunotherapy toxicity clinic, one of our endocrinologists, Dr. Zoe Quant, has done a lot of work looking at genomic biomarkers for development of endocrinopathies, including a type 1 diabetes presentation. So one of the thoughts that we've had is actually using AI together with continuous blood glucose monitoring to see if we can find early signals of abnormally elevated blood sugar to avoid, morbid outcomes and inpatient hospital stays. So just one example of, I think, how we could leverage AI in this space.
And I'll just chime in with one really obvious example for AI, which is the image analysis with our existing images, but also with some of the emerging imaging approaches, some of these immune response type imaging modalities. We don't even know how to read these scans yet, so we've got to collect a lot of different ways of looking at the images and start to pull out what's relevant, what can we measure, what can we make decisions based on. So that'll be important in the future.
Yeah, we actually have quite a robust AI program at Stanford, particularly centered around our dermatology and now leaking into our advanced melanoma program because of the expertise with skin cancers. But I think one of the key areas when I think about duration of treatment as well is looking at patterns of response and patterns of scans. And we've gotten interested in the question of, there's been discussion about flare on a PET, and does initial flare actually predict strong response because you're seeing an intense immune response initially on an early PET. And there's been a cooperative group trial that's been discussed at length looking at flare on a pet. But I think trying to use AI and other large data analysis to try to look for patterns of response in large data sets may be very helpful to us when we think about biomarkers rather than trying to pull these out from individual trials of I took part in actually you showed one of my patients from when I was at Memorial Sloan Kettering with the imaging trial. These all tend to be very small, and even our, the Checkmate 153 trials, a couple hundred patients, but if we can start pooling large data sets and inputting large amounts of data to look at patterns, I just want to caution that, first of all, AI is generative, right? And so it is hypothesis generating, it is not hypothesis testing, right? So we can use this to generate hypotheses, we still need to do clinical trials based on that. And making decisions based on anything that AI suggests, I think, is a very dangerous proposition. But certainly to use that to generate hypotheses to run trials, absolutely. And I think that work is starting to gain a lot of traction.
Thank you. I'm glad to have been wrong about, yes, Ashkan.
Can I ask a quick question?
Of course, you own this conference.
Oh. and that is, let's see here. In regards to patients who have immune-related adverse events, and they're placed on low-dose steroids and maintained on their checkpoint inhibitors, do we have any data to assess whether those patients do just as well as those who are not on, let's say, any steroids?
Yeah, there is some, and thanks for picking up on the caveat earlier. I think that there is a difference, between giving high-dose steroids early on in a treatment course versus kind of the scenario you described where maybe it's very low dose, maybe later in the treatment course to monitor a delayed and or chronic side effect. It's a little bit, I think that data is a little bit siloed right now for certain IRAEs. Certainly other people can comment, but for example, I'm thinking of a certain data set from the Hopkins IR Talks group, where the rheumatologist who co-directs their clinic was able to put together a series looking at patients with rheumatologic kind of arthralgia type side effects who were maintained on low-dose steroids, and that did not seem to adversely affect their cancer-specific outcomes.
So that's actually related. It'll come back to you, Katie, but that's actually related to the second to last, the penultimate question, which is about the relationship between both the severity of IRAEs and the tumor response, and whether certain types of AEs correlate better with anti-tumor responses. So I'm glad that the questioner asked that, because all of when you think about the possible negative effect of using immunosuppressive therapy to treat AEs on what the tumor outcome is going to be, not only does it have to do with early versus late and so forth, but also that patients who require treatment of AEs have a vigorous immune response, and we know that certain AEs are related to favorable outcomes. So when you want to subtract the possible steroid effect or the immunosuppressive effect, you're subtracting it from a different outcome than for patients who never got AEs. For patients who never got a response. So in that light, do you want to talk about whether there's certain tumor types or certain IRAE types that are more likely to go in one direction or the other?
Sure, I can comment a little bit on that, mostly through the lens of being a melanoma medical oncologist. If you go back, excuse me, if you go back to kind of one of the original questions, really, which influences all others, which is, why do IRAEs happen in the first place? I think maybe that's some clue to why we see certain IRAEs in some tumor types and not others. For example, within melanoma, I'm thinking of some cross-reactivity between the T cell and its target. Sometimes there's cross-reactivity between what they think an antigen that is present on a tumor, but also in other tissues. So in the case of melanoma, I think we pretty frequently see vitiligo as a cutaneous side effect, and that seems to be less frequent in other cancer types. And certainly, I think there has been some data correlating that IRAE, as well as some others with improved response.
Can I just I'll give an opinion.
Please do.
So on that data set, I think you're quoting Katie, that there seems to be a 10 milligram above bad, 10 milligrams below okay. I think like everything, there's not going to be that hardened rule. And I almost never will give checkpoints and something to suppress a toxicity from. I'll just have to reevaluate. Certainly if it's an adjuvant patient and I'm having to give them prednisone for some arthralgias, I just won't give them the adjuvant therapy anymore. If it's a metastatic patient, then you have a harder decision to make. But I find myself, and I'd be curious if anybody else gives water and fire at the same time.
Yeah. I think it always depends on the scenario. So, I think first and foremost to talk about, high versus low dose. We published this when I was a postdoc. There are data looking at high versus low dose steroids and timing of those steroids, and high dose early blunts a memory T cell response, right? So you may get an initial response to immunotherapy, but you may lose that response pretty quickly, particularly with discontinuation. And that was validated in a humans, group with ipilimumab, so some caveats there, that we rarely give ipi alone anymore. But the biology of the T cell, I think, doesn't change all that much in that setting. So I do think there is some validity to this, high dose early, bad, low dose later, probably not so bad, maybe not totally okay, but maybe not so bad. Absolutely. In the adjuvant setting, when you don't know if a patient absolutely needs treatment or not, I think there's very little reason to give anybody immunosuppression plus checkpoint blockade. In the metastatic setting, when they don't have a targetable mutation and maybe don't have another good option, particularly in melanoma where we have very little else to do, patient may not be trial eligible because of an IRAE, et cetera. I actually do it a lot. I do it with infliximab or vedolizumab for GI toxicity. We have a case series that came out of our group at Memorial Sloan Kettering showing the safety of doing that and efficacy with doing that. There's a similar case series from MD Anderson. Certainly 5 or 10 milligrams of prednisone for low dose arthritis, for unmanageable arthritis arthralgias. Tocilizumab, and Jeff Weber's done some beautiful work on that. So I think it's context dependent, right? Absolutely in the adjuvant setting, if you don't know that a patient needs treatment, pushing past toxicity is not ideal. In a metastatic setting, if the alternative is dying of your cancer and you really have very little else to do, and you are sure that the patient needs treatment, like I may have tried a treatment interruption and then the patient progressed, right? I don't usually routinely do it just without trying to give them a treatment break and seeing if they're, if they continue to be responsive. But if they need treatment, I think there are data out there that suggests that you can do that safely with a lot of monitoring and experience, and that, it can be effective in the right patient.
Thank you. I don't think it's important for me to say how I do it because it's somewhere in between. Are we ready to, right? Yeah. Okay. So guys, we'll take a break. I'm trying to get us back to caught up, and if so, we would have to be done with our break by about 11:40, which is probably not realistic, but why don't we try for 11:45 sharp, starting back again?